This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. I'll start with an announcement. First of all, just a reminder, everybody, that the Herslogue Winger Society meeting is coming up. So that's for our trainees and for our former trainees, and it's an alumni meeting, and it's going to be on the 16th of April. It's a good opportunity to meet with some former trainees, and I encourage you to attend. It is actually our major fundraising event for the fellowship program, and it's been very good. We keep it pretty concise. We try to end at a reasonable hour and everything, and I encourage you to think about coming. It's open to faculty and fellows. With that, we'll get going with this morning's cardiovascular grand rounds. Today we have Anshul Patel with us today. Anshul is director of the Arrhythmia Center at St. Joseph's Hospital. Anshul joined us several years ago after the Emory St. Joe's merger. He did his medical school at Hopkins and his rest of his internal medicine cardiology EP training at the Mass General. He's been a welcome addition to our division, and he's going to talk about a topic here that's interesting to me: preventive EP. How do we prevent EP? That's good. But it'll be interesting. One of our probably most challenging and sometimes painful arrhythmias for us to deal with in general cardiology anyway, AFib. Anshul?
Thanks. Well, I'd like to thank Bob certainly for the invitation to speak about a topic that probably not a lot of you think electrophysiologists are interested in, but I think it's important, particularly when you hear us often talking about the latest ablation technique or the latest device that we're putting in patients, to really kind of take things back to the heart of the matter, and look at what we can do maybe upstream to prevent some of these problems rather than just dealing with the treatment. So these are my disclosures. So atrial fibrillation has obviously been around for years. It's kind of considered the back pain of cardiology. It's a problem that a lot of us don't necessarily want to deal with, but have to. Cushney and Edmonds described it as auricular fibrillation back in 1906. Einthoven published the first EKG, and Thomas Lewis really made the connection between the EKG and the clinical condition. The classification of atrial fibrillation is important because I think it sort of gives us a baseline of how to talk about the condition, and the terms that we use in electrophysiology don't often necessarily percolate into the rest of general cardiology, but in terms of this talk, the way we'd like to describe it is when atrial fibrillation is first detected, paroxysmal atrial fibrillation is one that's basically self-terminating, usually less than 7 days in duration. Persistent atrial fibrillation is actually atrial fibrillation that lasts more than 7 days and requires some kind of intervention to terminate, whether it be cardioversion, electrical, or chemical. And permanent atrial fibrillation kind of is where the old chronic term was used, but really for those patients that you've decided to leave an AFib, either because it was a medical decision or you couldn't ever get them out of it. So the clinical impact of atrial fibrillation is not really something I have to talk a lot about to this audience. We know that it's a huge problem in healthcare and in cardiology, particularly because of its risk of stroke, its association with worsening heart failure, and the big role it plays in hospitalizations. Hospitalizations for whatever reason, and certainly half of all hospitalizations for arrhythmia. And there is about a 1.5 to 1.9-fold increase in mortality in the general population as well. So we certainly know it's a big problem. I want to start kind of with a patient that really brought all these issues to a head for me. And really, when I see patients like this, I often ask myself, what the right thing to do is, and how we're going to approach it. And this was a 62-year-old woman who came into my office with a history of hypertension, referred for symptomatic persistent atrial fibrillation. I see about 20 of these patients out of my 30-person clinic every Wednesday. Cardioversion had been attempted but had failed. She was started on flecainide and toprol and had a successful cardioversion a month later. She maintained sinus rhythm for only about 2 weeks and certainly had improved exercise tolerance and well-being in sinus. So obviously, this is one of our garden variety patients. They come to us sort of for the next steps in managing their atrial fibrillation. But when we go to our pertinent physical findings, this obviously gives us pause. So her height was 64 inches and her weight was 308 pounds. Her BMI was 53. Her heart was irregular with a variable S2 and no murmurs. On review of systems, she mentions some daytime hypersomnolence, and her partner reports snoring. Interestingly, her echocardiogram is actually relatively normal. Her EF was preserved, and her left atrium has some mild dilation. So I guess keeping all of this in mind, I'd like to sort of open it up to the audience of what you would sort of recommend next. I guess we just have a show of hands here, but how many people think catheter ablation is a good option for her? Not many. Okay. How about B, weight loss and exercise training? Sure, why not? Referral for a sleep study? Yeah, there. Bariatric surgery? Yeah, some of that. Or maybe all of the above. All right, well, we're going to come back to this case. I think hopefully after we've finished the talk today, we'll have a good sense of what the right thing to do is, or at least what we did. So the management of atrial fibrillation, after you sort of make the diagnosis, has sort of been this three-pronged attack. You know, we think about rhythm control, we think about rate control, and then obviously we think about stroke prophylaxis. And that's really where the focus of a lot of our management has been. And I give a little attention there to prevention, because I think in this patient in particular, you know, we want to see what else we can do, and maybe prevention should be broadened to sort of what we can do to modify risk factors for atrial fibrillation. So we have problems with management. We know that the drugs that we have for atrial fibrillation are not perfect. This was the efficacy of antiarrhythmic drug therapy at keeping people in sinus rhythm for 6 months. And really, it's about a 50-50 shot for most medications. Amiodarone's a little more successful, but you know, it has some toxicities, and it may not be something you want to start in a 60-year-old woman. Catheter ablation, you know, certainly the answer to almost everything we say in electrophysiology. This is Michel Hassaguer's paper in 1998 that really revolutionized the management of atrial fibrillation by identifying ectopic foci in the pulmonary veins that are triggering atrial fibrillation. I promise these are only a few of the electrograms, or maybe one or two of the electrograms I'm going to show today, but basically you can see in sinus rhythm here, a sinus beat, there's an atrial signal, there's a pulmonary vein potential, and then a PAC that's arising from the vein. So the pulmonary vein potential comes first and then makes its way out to the atrium. And these potentials can go on to trigger atrial fibrillation, as you can see here, and we know that if we do really cool things to basically isolate these veins, we can eliminate atrial fibrillation in a certain subset of patients. And so we have a lot of new tools out there to help us do that, and you may see things like this. We have great force sensing catheters where we can know where we're touching and make sure we don't perforate the heart. There's all these new balloon catheters that are coming out, and a lot of our focus has really been on treating atrial fibrillation after the diagnosis and seeing what we can do. But there's even a new procedure where we're trying to go basically surgically and endocardially, this convergent AF ablation that we started up at St. Joe's and are now doing at the rest of the hospitals, where we're helping with the help of our surgeons for these really long-lasting persistent atrial fibrillation patients. We can do these amazing lesions where we basically can ablate almost the entire right and left atrium. All right, so these all seem well and good, but there is a problem with this, and you know, this is sort of the dark secret in electrophysiology, where if you really follow out these patients for a long, long time, and these are select studies, and we always have to keep in mind that these are probably relatively early experience AFib ablation patients that we're able to now follow and get some long-term follow-up data on. So things have changed, and we have some new tools, but there is a problem. So even if you look at paroxysmal atrial fibrillation patients, which are supposed to be our slam dunk patients, the one that we can cure with one procedure, if you really look at the index procedure success over the long term, it may be only about 50%. Now, originally we thought it was 80 to 90, and it may be closer to 60 to 70, but this is some of the data that's out there. And then the clinical outcomes suggest that even if you go to 1 to 5 procedures, you can get about 80% of those patients in sinus rhythm. And so with other technologies like cryoballoon, that might be a little bit better in some patients, but not necessarily all patients. And then as you get more stubborn atrial fibrillation, so what we call persistent or long-standing persistent, so those patients that have been in AFib for over a year, you know, the index procedure success may be only 20%, and even after 1 to 5 procedures, you may only get 45% of those patients in sinus rhythm. So, I mean, there's obviously a problem here. You know, we're obviously dealing with tougher and tougher patients patients with a lot of other risk factors, and it's affecting our overall success. So I want to switch gears a little bit so we have a background of what we're dealing with and the types of patients that now we have to manage with atrial fibrillation, and I want to really shift the focus to prevention. So these are some of the modifiable risk factors for atrial fibrillation, and certainly when I saw that patient come into my office, the first thing I think is, she really needs to lose a lot of weight. And but how do you approach that after the fact is always a question, and can you really do things even after people have atrial fibrillation to change their risk factors and actually affect the outcome. So these are some of the ones that have been described in the literature. I'm going to focus on 4 of them today, the top 4, but basically obesity, exercise, obstructive sleep apnea, alcohol. Diabetes mellitus and hypertension have been both linked to atrial fibrillation, but don't really have a lot of time to go into that. I'm sure you get a lot of talks on diabetes and hypertension here, but obviously, obesity we know is a huge problem. This is a global survey of obesity. And basically, in the developed and in developing world, we know that the trends are pretty startling about the numbers of patients or people that are clinically overweight and obese. Interestingly, this seems to track pretty well with the overall prevalence of atrial fibrillation. This is some Mayo Clinic data from Olmsted County that's projecting somewhere between 12 and 16 million patients by 2050 will have atrial fibrillation. This has also been validated in some other studies, basically looking at the number of patients that are going to have this, and we see the general trend seems to be very similar. So if you look at the Framingham Heart Study that obviously has been described in no numerous papers, but basically following a cohort of patients in Framingham, Massachusetts, and their offspring, and even up to their 3rd generation, we know that obesity gives you about a 50% increased risk of atrial fibrillation. And this was true in both men and women, as you can see here in these Kaplan-Meier curves. Similarly, in the Women's Health Study, for every 1 unit of BMI increase, there's about a 5% chance of developing atrial fibrillation. And so it's been fairly clear from epidemiologic studies that obesity is linked to it. And even in large meta-analyses looking at over 600,000 individuals, for every about a 5-unit increase in BMI, there's about a 10 to 29% greater increased risk of incident, postoperative, and post-ablation atrial fibrillation. And we know that it's clearly a modifiable risk factor for the condition. So, the pathophysiology of how obesity can cause atrial fibrillation, has been postulated to be linked to genetic factors. There's some clinical correlates, coronary artery disease, but I want to focus on 2 things. Really sort of the inflammation and oxidative stress aspect, and really this whole idea of focal adiposity. So we know that obese patients are generally fat, but there's also fat that can really localize around the heart, what we call epicardial fat, and it's interesting how that can impact the atria. So this is an MRI just showing what epicardial fat looks like. This is a clinically obese patient, and you can see these blue highlighted areas show the fat really sort of encapsulating the heart. And when it does, it can actually do a lot of things structurally and through paracrine factors to impact the atria and atrial fibrillation. So there's 2 ways it really does this. It actually directly infiltrates the atrial tissue, which is a little bit gross, but also can actually have a big impact on atrial fibrillation. It's also a medium for paracrine modulators of oxidative stress and inflammation, and these are some of the ways that it can do that by fatty infiltration, causing fibrosis. There's inflammation, oxidative stress, and even affect cardiac muscle activity. And it can affect both the triggers for atrial fibrillation as well as the substrate itself. So all these markers of inflammation that are out there, including CRP, IL-6, TNF-α, have all been associated with the severity of AF and chances of AF recurrence. And interestingly, epicardial fat has been identified as secreting all these markers. Also, reactive oxygen species are actually interestingly produced more in epicardial fat than subcutaneous adipose tissue. So that's one way that it impacts it. And actually, you can prove this in a sheep model. So this is an interesting paper out of Australia where they basically fed 10 sheep a high-calorie diet for 36 weeks and kept them fat for another 36 weeks, and another 10 sheep were kept lean over that same period. So really not a long period of time, and at the end of it, obese sheep were really twice the weight of lean sheep and had significantly more body fat. And they did a lot to these sheep. They did an EP study, they did electroanatomic mapping, hemodynamic assessment, echo, as well as the histologic and molecular analysis, including TGF-beta expression. So these obese, sheep were fat. The weight was actually nearly double that of the lean controls, and it really percolated into their heart. The left atria were larger, the LA pressure was higher, and even their systemic pressures were higher. And when they went in and actually did voltage mapping, so this is an electroanatomic mapping system called Cardo that basically can give you a 3D rendering of the atria when you take points with a catheter, and you can see that the healthy controls had a lot of purple voltage, and purple is healthy, and the obese animals had these patchy areas of scar and low voltage. And actually, when you even did histologic analyses of these hearts, you can see that the controls had fairly clean-looking myocardium with clear delineation between the epicardial fat that's in some of these pigs and the myocardium itself. And the obese ones actually had some direct infiltration of the fat into the muscle tissue itself. And you can imagine how this can alter the electrical properties of the heart. And then when they even looked at things that cause fibrosis, including TGF-beta, they saw that the obese sheep had more fibrosis in the atria and actually had more expression of TGF-beta protein, which is one of the markers of fibrosis as well. So we can see in animals that even over the short term, you can actually really alter the electrophysiologic substrate and predispose these sheep and probably patients to atrial fibrillation. So this has been shown in human atria as well. You can see up here that there's some fatty infiltration, and actually this pink staining is for myofibroblasts, so you get fibrosis as well. This affects conduction velocities. As you get more fibrosis, the signals don't really travel quite as quickly, and they're also more deranged, as you can see in this picture. So in human studies, what have we really found? So in patients who are undergoing AFib ablation, what happens if you look at their voltage and what electrophysiologic properties are altered? You can really not see a huge difference in LA voltage in some small studies, but there were definitely differences in effective refractory period, LA volume, and conduction time. Now, keep in mind, these are all patients with atrial fibrillation, so there may be some fibrosis in all of these patients. But there was definitely some difference in people that were obese. And what can you really do to help these people is really the other question. So from a prevention standpoint, what can you do? So, we similarly, think about this when we talk about coronary disease and hypertension, but can you really say that decreasing someone's weight is going to affect their burden of atrial fibrillation? So the study from Australia as well actually was quite heroic, really. I mean, they basically screened 1,400 patients with atrial fibrillation, identified 815, and actually entered 315 patients in the study, where they really tried to get them to lose weight. So they did face-to-face motivational counseling with 3-month reviews. They gave them a meal plan with behavior modification and basically had a fairly modest weight reduction goal of 10%. It included exercise prescription and then looking at all their other risk factors, including smoking, sleep apnea, alcohol use, and hypertension. And divided them into 3 groups: those who had more than 10% weight loss, those who had 3 to 9%, and those who had less than 3%. And they tracked a lot of the general directionality of their weight loss, whether or not it was linear, whether or not they had gain, whether or not it was fluctuating, and they followed them for 48 months, which is pretty remarkable. And basically 66% of the patients in the greater than 10% group did maintain this loss at 34 months and showed there was a 6-fold decrease in AF burden. So, and that's pretty amazing, only with a 10% weight loss that you can show without ablation and without drugs that you can decrease people's burden of atrial fibrillation. And really, if you do include drugs and ablation, the total AF freedom is pretty remarkable as well in comparison to those people that don't lose weight. So there's some hope. There's something that we can do for these patients. And we know that even after catheter ablation, obese patients tend to do worse. This was a small study just looking at 109 patients and showed that BMI was a linear variable that was a predictor of failure. We also know that obese patients tend to have more complications from atrial fibrillation. So even those patients that you're going to take to these procedures, there's a Vanderbilt AF registry that looked at a variety of complications, including vascular, pericardial effusions, acute lung injury, stroke. And basically, BMI over 40 was associated with a threefold increase of complications. Interestingly, being a woman was also associated with an increase in complications. And you can see these numbers are pretty dramatic. So I think if you can help these patients upstream, maybe will lead to better long-term success, even post-ablation, and potentially less complications if you have to take these patients to procedures. So if you really take a large group of patients and you try to figure out if you can modify all these risk factors, can you really make a difference? And this was similarly, this was a similar type of patient population, but these were patients who were going for ablation. And if you take a very aggressive management tack towards them and look at weight management, hyperlipidemia, glucose tolerance, hypertension, sleep apnea, and try to fix all these things, you can really show a remarkable difference in their outcomes. And these are some of their baseline measurements. This was called the ARREST AF cohort study. And again, for single procedure AF-free survival, these are patients undergoing ablation. You can show a dramatic difference in those patients who had risk factor modification versus those who didn't. So obesity we know is a problem. We know that if we fix obesity or try to modify it as best we can make a big difference in these patients. So let's move on to sort of other things that we can do to help them. Exercise has an interesting relationship to atrial fibrillation because we see a lot of patients at both extremes. We see patients who don't exercise a lot, and then we see patients who exercise, I don't know if it's too much, but I've had a few ultramarathoners show up in my office with atrial fibrillation. So there may be a difference at the extremes of exercise. Now, obviously, the benefits of exercise probably are going to outweigh those for the most part. But in a small subset of patients, you know that if you do push your body to the extreme, you may actually cause atrial fibrillation. So looking at this epidemiologic study, which enrolled 20,000 patients between 1986 and 1987 and were followed for 20 years, 750 were diagnosed with atrial fibrillation. And basically, they assessed resting heart rate objectively and exercise activity by questionnaire. And there was this sort of J-shaped curve. So we know at low exercise levels, there was an increased risk of atrial fibrillation, but really vigorous activity, at least in these patients, it was a Scandinavian population, seemed to give you somewhat of a higher risk, although obviously this is just a hypothesis sort of generating idea. But in meta-analyses in endurance athletes, actually, if you combine the small number of studies that are out there, there seems to be about a 5-fold increase in risk of atrial fibrillation. So we know at one extreme there may be a slightly higher risk, but we certainly know at the low end of things as well, there's going to be an association between atrial fibrillation and exercise. There's been interesting things in terms of types of exercise that people have recommended. This was a study that came out of the University of Kansas by DJ Luccaretti. But in a single center study with 49 patients, actually yoga was shown to help. So with a 3-month pre-intervention observation study followed by twice-weekly 60-minute yoga training, you could assess AFib by remote monitoring and a symptom diary. And actually, they did objectively look at both symptomatic and asymptomatic episodes of atrial fibrillation and looked at quality of life studies and actually showed that yoga in the small studies seemed to help both symptomatic and non-symptomatic atrial fibrillation episodes. There was also a trend even to reduce those episodes that were asymptomatic. There was a more recent study that got some press, which was really a nursing study, randomizing 80 patients to yoga versus standard therapy. It didn't really look at AF burden, but overall the yoga people felt better. So it may be something as easy as yoga, and maybe for some of these obese patients that I'm not sure the patient that I saw in the office could do it, but anyway, for a low intensity exercise may also help people with their atrial fibrillation. So these guys in Australia are really motivated, but they also did another study really looking at whether or not you can improve people's exercise tolerance and affect atrial fibrillation, and really did a similar study where they looked at obese patients with atrial fibrillation, looked at their baseline exercise tolerance, and then tried to get them only a 2 metabolic equivalent gain in exercise tolerance, and really showed if and tried to see if that could help people's atrial fibrillation. So fairly modest, goals in these cases, but I think we sort of get a little disheartened when we see these patients in the office and they're not very motivated. But even if you can get them walking a few times a week, you can really show them that there's data out there to show that they're going to get better. So 825 patients were offered weight management and exercise programs. 308 were enrolled in the study. They had their baseline exercise tolerance determined, and they were offered weight management program and a tailored exercise program, which was, again, like I said, fairly mild in intensity to start at 20 minutes 3 times a week, and then increase that up to 200 minutes per week. And their gains were characterized as greater than or equal to 2 METs or less than 2 METs. And again, with ablation-free, drug-free AF freedom, you can see those patients that at baseline were not very fit tend to do worse. And those who are at 100% of what they should be did better over time. And even those patients, if you followed them, the guys who could not really exercise even after ablation and drugs tail off quite dramatically. But can you make a difference in these people? And you can, and actually mostly you can see that the difference in the less than 2 MET group versus the greater than 2 MET group came down to some measurements of their left atrium and things like that, but really it had to do with AF frequency, duration, and episode severity. And again, you can see that those who gained some exercise tolerance did better long term. So here again, we have the benefits of exercising training in AF. We know that over the short term, you can reduce AF burden. Long term, there seems to be increased AF freedom, and these are some of the mechanisms that are postulated. But again, only 3 to 5 times a week, and if you can get them up to 200 minutes a week, that's great. But even if you could start at 20 minutes 3 times a week, you can probably make a difference for these patients. So the next thing I think is really interesting because we get a lot of questions about it, but obstructive sleep apnea and its role in atrial fibrillation. Obviously, our patient that we talked about had some indicators, including daytime hypersomnolence and a partner who indicates snoring. And I think for us as electrophysiologists, we see so many patients with atrial fibrillation. A lot of them are obese, and it's really now become part of our responsibility to identify patients who have sleep apnea and referring them for the proper treatment. So the epidemiology of obstructive sleep apnea and atrial fibrillation, again, a fairly clear association in Olmsted County, where if you had a retrospective study of over 3,500 patients over a follow-up of 4.7 years, there's about a 2-fold increased risk of atrial fibrillation in these patients. The Sleep Heart Health study showed similar results where people who had baseline somnograms somewhere between 1995 and 1998 had follow-up sleep studies, and actually just during the sleep study itself had atrial fibrillation assessed, and there was about a 5-fold increased risk of atrial fibrillation, and interestingly a lot of other arrhythmias, including some non-sustained VT and PVCs. And so you can see that the patients with sleep disordered breathing had a higher rate of atrial fibrillation even at a one-time measurement. And so the association between sleep apnea and atrial fibrillation is similarly complex. Obviously, we know obesity plays a role in sleep apnea, so the lines are certainly blurred, but we know that there's intrathoracic pressure changes that are a problem, there's LV dysfunction, there's a pro-inflammatory state and alternations in the autonomic tone. We know that there's a lot of ganglionic plexi behind the atrium, some of which we actually ablate while we're ablating the rest of the atrium during our procedures, and that also can impact atrial fibrillation. So I thought this was an interesting study where we actually took a bunch of healthy volunteers who were recruited to do the Mueller maneuver, which basically is forcing inspiration through a high-resistance orifice, so trying to simulate part of the problems in sleep apnea. And basically, in an acute echo study, looking at what happens to the left atrium and left ventricular end systolic dimensions. And so when you had these people do the Mueller maneuver, the LA volume and end systolic dimension decreased, and they had a temporary decrease in their EF. And actually, when they released it, there was a compensatory increase in LA volume and EF. So just by doing that, there's alterations in the dynamics of the left atrium and the ventricle, and there's this whole idea that you're actually causing the left atrium to stretch and then relax, really more than it should. There's some suggestion that even coming up and slamming against the thoracic wall to some extent can impact this. And you can see what happens when they do this. So it's sort of an interesting idea of how sleep apnea may actually directly impact LA volume and cause some stretch to those to the myocardium. So as I said, I think it sort of now becomes part of all of our responsibilities to identify these patients in our clinics. And there's been a lot of progress in diagnosing sleep apnea. I know there's been insurance coverage issues with polysomnograms, and now people are trying to do more things simply, and so you might even have an iPhone app that can measure your oximetry on the left and record what it does overnight to identify patients who have sleep apnea. There's another company that's directly marketing to electrophysiologists who have a similar sort of home overnight oximetry, and trying to get cardiologists involved and really invested in diagnosing the problem. So we know that there's, the main treatment happens to be a CPAP machine and not a taser, but I think for us, we want to know that treating these patients is really going to make a difference. And we know that even in patients who have catheter ablation, who are identified as having obstructive sleep apnea, we know that it is actually a negative predictor for our success. So there's some difficulties in really getting some consistent ideas of what happens to these patients, because it was different in how the sleep apnea was diagnosed. But in general, I think we know that sleep apnea is going to affect our outcomes as well. And then we also know that if you treat these patients with CPAP, you can actually make a difference. And those who had an AFib ablation with sleep apnea who were treated with CPAP did better than those who were not. And there was about a twofold increase failure rate in those patients who are not treated with CPAP post-ablation. So, we know it's a big problem. We know that it can obviously has a link to developing atrial fibrillation, but not treating it even after you identify it can be a problem for AF freedom, either pre or post-ablation. So the last thing I just want to touch on, more out of interest, more than anything else, is because we get a lot of questions about alcohol's relationship to atrial fibrillation, is this whole idea of the holiday heart. So it was first described in 1978. Actually a hospital in New Jersey, where 32 episodes of dysrhythmia, most commonly atrial fibrillation in 24 patients, and the events seemed to cluster around weekends and holidays. So the Monday after the weekend, a lot of these patients were showing up, and the events that were later in the week actually seemed to be around Christmas and Thanksgiving and holidays like that. So we know this whole idea of the holiday heart syndrome, but what is, and that's really been linked to binge drinking and alcohol, but of binge drinking of alcohol and atrial fibrillation. But what happens to those patients who don't binge drink, and whether or not you should recommend these patients should stop drinking? So in the Copenhagen City Heart Study, about 16,000 men and women answered a questionnaire about beer, spirits, and wine consumption at up to 3 visits, and they identified cases of atrial fibrillation by EKG data and a validated hospital registry. And then the consumption, the moderate range, was really not associated with atrial fibrillation, but if you do have more than 35 drinks a week, there does seem to be an increased risk, and 5% of AF cases overall were attributable to heavy alcohol use. And in the Framingham Heart Study, similarly, if you were a heavy drinker, more than 3 drinks a day, you had this modest increased risk, but probably 1 to 2 drinks a day is not necessarily associated with it. I would tell you in my patients, we get a lot of questions about how much they can drink or whether or not they should cut alcohol, but generally out completely. But generally, I say if it's moderate, maybe 1 drink a day, they're probably not really impacting their overall risk of AFib. So conclusion. So prevention of AFib obviously is an important adjunct to the management of a disease that has increasing prevalence and healthcare burden. There are a number of risk factors that we've identified for atrial fibrillation that clearly can be targeted for modification. And then data from multiple studies support that modifying these risk factors can really improve AF burden both pre and post ablation. So I'll give you just some follow-up on my case study. So we did refer her for a sleep study, and amazingly enough, she did not have sleep apnea according to them. So I guess you can be surprised. She actually declined a bariatric surgery referral. She agreed to a nutrition referral, but as a lot of our obese patients have problems with, she could not exercise due to her knee and hip issues. But we went back to a referring cardiologist who strongly urged her to have a catheter ablation procedure, and maybe with a variety of pressures and really not having a lot of options to help her, we actually did take her for an AF ablation. So just as I had showed you, these patients have a high risk of complications, and we're being honest here. So she did actually have a pericardial effusion near the end of her AF ablation. We drained it. She did fine. No surgery was needed. Amazingly enough, her AF improved. Post-ablation, it went from being persistent to paroxysmal. We put her on Ticacin, but she kept complaining of dizziness, and we put her on a monitor, and she was having 3 to 5 second conversion pauses in and out of atrial fibrillation. So we discussed, the options at that point, which potentially would be putting in a pacemaker and continuing her on Ticacin, or considering her for a repeat AF ablation. And she was game, and I was game, and we did it. The procedure was uncomplicated at that point, and she's doing well. 3 months post-ablation, currently still on Ticacin. This is a reminder for me to stop. Okay, thanks.
Thanks. That's really interesting. It was all sort of news to me about the epicardial fat thing. And that's, there's a similar literature in the vascular world where they look at perivascular fat and its role in atherosclerosis. So I was wondering if anybody, obviously you can't biopsy that in people, but with the weight reduction or sleep or any of the other, particularly the weight reduction, I guess I'm not aware of people looking too much at biomarkers of that, or are there any specific, I guess the question is, are the biomarkers, any of them really specific for AFib, or is it just sort of the general inflammation? Because there's a lot of markers that say, get better with weight reduction. Is there any?
I think it's been more general markers. I don't think that there's anything specific that's been, linked to atrial fibrillation, as you can sort of follow that, as a way to see how they're really responding to your treatment. But I think it would be nice to see.
Do you have any questions from the group? There you go, preventive cardiology.
Really nice. A really nice job. I'm glad to see that there are preventive EP docs out there. And I do think more and more that we're all going to be called upon to be more focused on cardiovascular prevention, whatever we do in the realm of cardiovascular medicine. So I know you didn't touch upon hypertension, diabetes.
Yeah.
Your talk could
I know, go on forever, yeah.
But I know that there had been some studies looking at statins and AFib.
Yeah.
I know Sam Dudley, who used to be here, was involved in one. I don't know if that ever came to completion, and was there any benefit for statin therapy? And then there's also literature about omega-3 fatty acids, both in the surgical and non-surgical literature in terms of their impact on AFib. But any comments about medical therapies that one could use, ACE inhibitors, that might have effect on biology and then risk of atrial fibrillation?
Yeah, so those are all interesting points. So it was really epidemiologic studies that looked sort of retrospectively to suggest that statins may have a role. I'm not actually aware of a prospective study that's looked at statins themselves.
Stop AF, or Dudley was involved in that study. I don't know if it ever finished.
Yeah.
I remember you were doing, Bashai was doing biomarkers. He was doing CRP. I don't know if it was BNP, and I don't know if that one ever came to completion as well.
Yeah. So so statins, I'm not really sure that that has really borne out. I know for a fact that the omega-3 fatty acid thing hasn't really been great. I think the only studies that have shown benefit for that have been in the post-cardiac surgery patient. So for post-operative atrial fibrillation, there seemed to be a modest reduction. And then the ACE inhibitor ARB story, I think the largest study was really the GISI-AF study that looked at valsartan and was really a negative study. So, I think from a lot of aspects, it's been interesting for ACE inhibitors, particularly their role in fibrosis and preventing it. There was a lot of hope for that, but really prospectively, we haven't really been able to show a difference.
Yeah, that was great. So the atrial appendage is viewed as this thing that should be eliminated, but is there anything? It seems like I've heard something recently about maybe what brought this up? There were some people who wanted to do prophylactic atrial appendage occlusion, like they're closing an ASD. They say, we should close the atrial appendage because it might be hard to get to if the people ever go into atrial fibrillation. Does atrial appendage play any role in, say, overall wall tension in the atrium, and is there any evidence that it may be of value functionally in preventing and enhancing normal atrial function and that sort of thing? I mean, it absorbs some right. Wall tension there.
Yeah, I mean, so a lot of electrophysiology is really focused on the appendage at this point. So from a lot of different aspects, I guess there's one aspect where you sort of look at its role in atrial fibrillation itself. And obviously there's the whole issue of whether clots form in it and what you can do with that. But just electrically speaking, particularly in patients with long-lasting, persistent atrial fibrillation. So that's really the tough of the tough, the people who've been in AFib for over a year. There are a lot of groups advocating that we isolate the atrial appendage. So either we basically burn around the ostium of the atrial appendage till it's electrically dissociated from the atrium itself. And then people have a lot of questions about what that does. What is that going to do for overall atrial function? Because we know the appendage can be very large in a lot of patients and can actually take up a lot of the atrium, and how much of the actual active emptying of the atrium is related to the contraction of the atrial appendage. But I guess in whatever echo studies that have been out there, the thought is that being in sinus rhythm is still better in terms of atrial function rather than being in AFib with a working appendage. So, you know what I mean? So it's sort of the overall benefit of sinus rhythm for atrial function seems to outweigh the size of the appendage in terms of how much emptying comes from there and what role it has in sort of the active contraction. So there are actually some trials that we're involved in here to prophylactically basically tie off the atrial appendage prior to ablation. So I don't know if you guys are familiar with the Lariat device, which is an epicardial suture that we can do with a combined sort of transeptal and epicardial approach to ligate it. So there is a trial that we're actually going to start to enroll in shortly that is basically going to ligate the appendage first, and then 6 weeks later come back for a traditional AF ablation. The Watchman device was recently approved. There is some data to suggest that the atrium can become somewhat silent after Watchman placement, and whether or not that may help, later in overall success for AF ablation. So there's a lot of interesting things out there. I'm not sure how much of all of it's going to bear out, but we're trying.
Okay. All right. With that, thanks so much for a really interesting talk.
The preceding program is copyrighted by Emory University.